Let's get started talking about hypertension. The incidence of hypertension or high blood pressure is on the rise in the United States, with at least 50 million people affected by it. By definition, the diagnosis of hypertension is given when the systolic blood pressure is greater than 140 millimeters of mercury or the diastolic blood pressure is greater than or equal to 90 millimeters of mercury. Hypertension occurs in 10 to 20% of people aged 25 to 45 and 30 to 40% of people aged 55 to 74 years. Although it is a silent disease in that patients usually have no specific symptoms, hypertension poses a major risk factor for coronary artery disease leading to heart attack, cerebrovascular disease, that is strokes, and renal disease or kidney failure. No antihypertensive drug is indicated for normal or pre-hypertension. Initially, goal blood pressures we strive to reach goal with lifestyle modifications. We want to, if they are stage 1 hypertension, even pre-hypertension, we want to initiate lifestyle modifications. Of course, we want to get them below 140 over 90 millimeters of mercury. The goal for patients who have diabetes or chronic kidney disease is different. Their goal would be a blood pressure of 130 over 80. Note that the thiazide type diuretics are given most for stage 1 hypertension. And then in stage 2, we would use a 2-drug combination for most, usually. Usually it would be a thiazide type diuretic and an ACE inhibitor. You're probably all aware and have heard about a white coat hypertension. Sometimes patients will get an elevated blood pressure reading when they're in a clinical environment. These people experience anxiety and apprehension, and thus falsely elevating their blood pressure reading. And yet, when they're outside of that environment, their blood pressure reading is normal. So it is important that they monitor their own blood pressures at home. I usually recommend them going to CVS or Walgreens because we have a really a good blood pressure machine there that can give us some accurate readings. Self-monitoring at home is practical and economical, and it should be considered before they have the ambulatory blood pressure monitoring, which is a non-invasive, fully automated system that measures blood pressure at preset intervals over a period of 24 hours. Knowing that untreated or poorly managed hypertension has adverse consequences on the brain, heart, and kidneys, it's very important that you identify the disease and treat it aggressively. For patients with essential hypertension, treatment is accomplished with medication and lifestyle modifications. However, in those patients with a potentially correctable cause of hypertension, prompt recognition and treatment of the underlying cause may cure or dramatically improve blood pressure control and decrease related injury to the blood vessels, the heart, the brain, and the kidneys. Now, excessive sodium intake is considered responsible for initiation of hypertension in some people. A high sodium intake may activate a number of pressor mechanisms and cause water retention. There is both primary and secondary hypertension. First, we will discuss primary hypertension, which also is referred to as essential hypertension. This accounts for over 90% of all hypertension in adults. The onset of age is 30 to 50 years of age. There is a family tendency. It has no specific identifiable cause, but it's due to the body's inability to regulate blood pressure within the normal range. Okay. Essential hypertension is treated with medication, diet, and fluid restriction, and is not technically curable. We can only manage it. It is modifiable. We see that in African Americans and those with from Puerto Rico or Cuba or of Mexican descent, they have more issues with hypertension. In other words, hypertension is more prevalent in these communities, and usually it is more severe in these populations. In these populations, there's also an increase in the incidence of diabetes, stroke, and renal failure. So diuretics are particularly effective in African Americans. ACE inhibitors are less effective in African Americans. Okay? African Americans produce less renin in their kidneys, and therefore they do not respond to ACE inhibitors as well. We do see with hypertension a higher mortality rate within the population of African Americans. Okay. Now, risk factors for hypertension include age. Men before the age of 55, it tends to be more common in men than in women before the age of 55. However, after the age of 55, hypertension is more common in women than in men. Men with hypertension are more likely to suffer a heart attack than a stroke. Alcohol consumption increases your risk of hypertension, and it certainly elevates those blood pressures. Cigarette smoking as well. And then diabetes is a risk factor. Elevated serum lipids, in other words, we have high cholesterol in these patients, that's a risk factor. Excessive dietary salt intake, and gender, at which we talked about both age and gender in the first part of this slide. Other risk factors are on this slide include family history, especially when we're talking about essential hypertension. It's not uncommon at all to have a patient report at the age of 30, everybody in my family at the age of 30 is diagnosed with hypertension. It's just hereditary. Obesity, a sedentary lifestyle goes along with that. We already mentioned ethnicity. And also stress, your level of stress, especially if it's sustained stress, and a socioeconomic status. Those at a lower socioeconomic status seem to have an increased risk of hypertension. Okay, so the RAS system, which stands for the renin-angiotensin-aldosterone system, which occurs in the kidneys, has a direct impact on hypertension. So let's review this physiological process. The kidneys are responsible for secreting renin in general, but some people can secrete an excess hormone, excess renin from their kidneys. And this causes, we'll go through the steps shortly, this causes two things to occur at the end of this system. One is arterial constriction. And remember, when vessels constrict, blood pressure goes up. Next, the end of the system results in aldosterone, increases in aldosterone, which results in the retention of sodium and water. That increases the volume, the intravascular volume, again, raising blood pressure. And here is the process. This starts down at the bottom. This is the normal process, the RAS system in the kidneys, starting at the bottom with number 1. Blood pressure falls. I like to always say that the kidney is not very smart. Okay, it doesn't know anything to do other than when the blood pressure falls to say secrete renin. Okay, renin is present to convert angiotensinogen to angiotensin 1. Then another enzyme called ACE, angiotensin converting enzyme, number 3 here, is responsible for the conversion of angiotensin 1 to angiotensin 2. Angiotensin 2 causes direct arteriolar constriction, and it promotes vascular hypertrophy and induces aldosterone secretion, as you see in number 5. Okay. So in people with essential hypertension, this system, this is altered. The mechanism is altered, and it contributes to the development and maintenance of hypertension. Okay. Here we see the fact that that sustained stress, this increased sympathetic activity, can also lead to elevated blood pressures. Now, it's normal for our blood pressures to fluctuate somewhat. I mean, all throughout the day. And if we're under a period of stress, our blood pressure will go up. But that is not what we are going to treat in the clinic or in the hospital. So we'll be treating patients who have sustained pathology, that there's something that they're subjected to stress hormones or stress over long periods of time. Okay, so we talked about primary hypertension. Now let's go back to secondary hypertension. Remember, this only accounts for less than 5% of hypertension in adults. Okay, this is the least common type of the two. However, it is the most common type in children. Okay, and you'll see why. Because typically children, most children do not have hypertension. Okay, with secondary hypertension, there is no identifiable cause. It occurs in a wide age range. It is severe and it is abrupt in onset. Okay. Secondary hypertension is potentially curable. That distinguishes it from essential hypertension because it is most commonly caused by stenosis or narrowing. So of the renal kidney arteries. Okay, so it does have an identifiable cause. All right, the most common cause of secondary hypertension is renal disease, even more so stenosis of the renal arteries versus actual disease of the kidney or the parenchymal disease. Stenosis is narrowing that restricts an opening, and renal artery stenosis occurs when a kidney artery narrows, causing a decrease in blood flow to the kidney. Each kidney is capable of regulating the body's blood pressure to assure that each organ has an adequate supply of oxygenated blood. And this happens by activating that cascade of hormones known as the renin-angiotensin system. But renal artery stenosis triggers the release of these hormones, which then causes hypertension. Since hypertension is the leading cause of strokes and heart attacks, this is a serious condition that requires diagnosis and treatment. Renal artery stenosis can also eventually lead to loss of renal function. But since one kidney can perform adequately by itself, both kidneys would have to be affected for kidney failure to occur. In about 30% of the cases, both renal arteries are involved. Arteriosclerosis causes 80 to 90% of renal artery stenosis. Smoking, obesity, advanced age, high cholesterol, and diabetes are factors which may increase the chance of developing atherosclerosis. There are less common causes, which we are not going to address at this time. Okay, so here we see an actual arteriogram that shows renal artery stenosis. The large vessel in the middle is the aorta, and coming off of that are the renal arteries. It appears that the patient's right renal artery is patent. But if you look on the right side of your screen, but the patient's left arterial renal artery, you'll see that it is restricted. There's a very small area where blood is able to pass and perfuse the kidney. Okay. This is a form of invasive testing. This is an arteriogram, or sometimes referred to as an angiogram. And this procedure is considered the gold standard of renal artery evaluation and is the most helpful in determining the diagnosis of renal artery stenosis and whether or not endovascular or surgical repair might be appropriate. So if renal artery stenosis is detected, as we see in this picture, the vascular surgeon will determine the method of repair. We can do angioplasty, which is an endovascular technique, and the word plasty means that it involves inflating a balloon within the narrowed artery, and this inflation of the balloon will widen the vessel and improve blood flow. The balloon is introduced through a puncture site, usually in the groin, and then we can do stent placement, where a stent, which is a metal device, is placed inside the artery and acts as a scaffolding device to hold the artery open. Stenting is usually performed at the same time or in conjunction with angioplasty through the very same puncture site. And then we see after the angioplasty that the stenosis has been removed. And the stenosis, I should say, has been improved. It has been successful. And we see the stenting has left it's left in place, the stent is left in place, but it is restoring the normal blood flow to the kidney. Consequently, the hypertension is significantly improved and sometimes even cured. Okay. Now, there is also sometimes this method of repair is required. This is the bypass surgery when there's renal stenosis. This method of repair involves an abdominal incision and a 7 to 10 day hospital stay. You can see that a graft is placed to bypass or go around the area of blockage, and thereby restoring blood flow through the graft and restoring blood flow and pressure to the affected kidney so that it doesn't continually secrete renin. So unfortunately, balloon dilatation with a stent placement cannot keep narrowed renal arteries open in a small, well, 20 to 40% of patients with this renovascular hypertension. So for these patients, we have open surgery is required. And this is just showing you another picture of that bypass surgery to improve or bypass the area of blockage. Okay, then we'll end here and move on to part 2 of hypertension.